Right, so this is our first lecture here. We'll go over a little bit of a brief overview of the course, some of the stuff we're going to cover, and then we'll start to talk about things like routes of administration. We're going to talk about receptor theory because that's going to be the basis for how all these medications are going to be working in the body. So again, I mentioned this is an intro to pharmacology. So you're going to have Pharm 1 and Pharm 2, and then you're going to have clinical pharm, who's actually the course director for that is Professor Quinones, who runs that class. That's where, again, it gets more into nitty-gritty details of like how you're using these medications, writing prescriptions and whatnot. So again, in Pharm 1 and 2, we're not going to stress so much about things like knowing specific doses of things. However, I want you to be able to know like how to look up things, how to find the information you need to write a prescription or to treat a patient. And then Clin Pharm gets much more into like, okay, how do you actually like apply this to a specific patient case? So you'll see that as you go through the curriculum. This one is 1 credit hour, only 16 hours of instruction, so not super heavy from that standpoint. And we'll have the 150 question test with the prescription assignment. You need a 75 or greater to pass. Again, the assignment is also here to help kind of cushion your grade a little bit, so the test is not like kind of a make or break for every single person, right? Unit 1, you can see we're going to cover things like terminology. We have to know the right kind of lingo in order to speak to these medications. We'll talk about routes of administration. Anyone know what routes of administration means? It's oral or IV or IM. Yeah, so we're going to talk about all of those, kind of the pros and cons of all those things. We'll talk about secondary messenger systems. So we're going to talk about what happens after a drug interacts with the receptor. We'll talk about kinetics of drugs. So we're going to talk about pharmacokinetics, and we'll talk about what that is and regarding things like absorption, elimination of drugs. And then some stuff about bioavailability, bioequivalence. We'll talk about that is a little bit later. And then special populations. So again, when you're dealing with adult patients, when we talk about drugs, we think about adult patients typically, but how do things change when you're dealing with a neonate versus someone who's, say, very old? So for instance, if you ever deal with kids, one of the big things they always tell you is that they're not just little adults, right? Because they are very, very different from a physiologic standpoint, especially when they're a neonate. Anyone know when the neonatal period is specifically? It's like the first 28 days of life. That's technically when they're actually a neonate, right? And so again, we'll talk about the definitions later on. But again, they are very, very different, very kind of very sensitive population. You want to be careful with. We'll talk about therapeutic drug monitoring and then how we can actually make dosage regimens for your patients. And then we'll have an exam review. So we'll do another Kahoot right before the test, and you'll have an idea for what kind of questions we'll ask on that exam. Okay. So anyway, you'll see the objectives for these as we go through. All right, definitions. Let's go over some definitions and make sure we're all on the same regarding medication. So when you think of a drug name, you usually think of 2 different types of names. So what are those 2 types of names? Generic and a brand name. Yeah, so typically either a trade name or a brand name, and then usually the generic name, right? So for instance, when you think of ibuprofen, what's a brand name for ibuprofen? Advil, Motrin. Those are 2 of the more common ones. And so whenever I'm writing tests for this class, I will always put the generic name first, and then I will put the brand name in parentheses. I try to do that because, again, ideally you should know these drugs based on their generic, because again, you can't really go wrong by knowing the generic. However, brand names are important too, and people are going to call these drugs by those names, and so you need to be able to recognize that. So for instance, a lot of people don't just say, okay, let's go ahead and give ibuprofen. They say, let's give some Motrin, right? Let's give some Advil. And so being able to recognize what those brand names are that are commonly used and kind of equating that back to the ibuprofen is important. And again, a lot of this class for Pharm 1 and Pharm 2, you're going to think a lot of it is memorization, but really a lot of it is recognizing these drugs and kind of what categories they're going to fall into and that sort of thing. So being able to recognize the generic and the brand is going to be an important way to kind of classify back, okay, what type of drug is this? What do I know about this drug based on its classification, etc. So anyway, so again, ibuprofen we kind of use as our example here. We have a pharmacotherapeutic classification. This is usually going to denote either the chemical kind of structure of the drug, or more often than not, it's going to be based on the mechanism of action of the drug, right? So again, in this case, ibuprofen is going to be an NSAID. And everyone's heard the term NSAID before, right? Anyone know any other NSAIDs? Aspirin technically is an NSAID. Meloxicam. What's the other big one you see over the counter? Aleve. Yeah, Aleve, or what's the generic for that? Naproxen, yeah. So again, these are the kind of things that a lot of people are familiar with just because they're available in the homes of most people. Right, so they're all fit in with that same category of NSAID, but if anyone ever wonder like what does NSAID really stand for, what does it actually mean? Well, it's a non-steroidal anti-inflammatory drug. So it kind of tells you a few things about the drug already. So what's the first thing it tells you? It's not a steroid, right? So again, when we're looking at anti-inflammatories, you're going to see steroids are a huge component of anti-inflammatories we use, but we want non-steroidal drugs because we're going to see there's lots of side effects with using steroids. And then the next thing we know about it, it's going to be anti-inflammatory, right? So what kind of conditions do you think we might use it for? Inflammation, right? So again, if I injure myself, I twist my ankle, which I almost did with my toddler. She likes to get out of the bathtub and then just like go running on the tile. And so when I almost slip and twist my ankle, guess what? Like I'm going to have inflammation, and I can use an anti-inflammatory drug for that. So again, kind of keys you into what type of drug we're actually dealing with in those cases there. More specifically, you can get into the mechanism of action of a drug. These are very important things to remember when you actually get into specific drugs, knowing what the mechanism is, because if you kind of know what the mechanism is, you're going to know how it's going to interact with the body. You know how it's going to how to interact with different disease states. You can usually guess what sort of adverse drug reactions you're going to get based on the mechanism. So this is an important concept to understand with each class of these drugs. So looking at that, we can see, and again, you don't have to memorize this slide specifically. These are just like the things we're going to talk about when we get into individual drugs. But when I say mechanism of action for an NSAID, these are going to work by inhibiting an enzyme called cyclooxygenase. So if you guys go back to that prostaglandin slide we had in physio a couple of days ago, you'll see that cyclooxygenase is an important enzyme for producing inflammatory mediators, right? So things like PGE2, other prostaglandins like that. And so by inhibiting prostaglandins formation, you inhibit inflammation via that, right? So again, it's good to know the mechanism there. And then our indications are going to be basically what disease states you're going to be using this for. So in this case, NSAIDs are going to be used as an anti-inflammatory drug. It can be used as an analgesic. What does that mean? Pain reliever, right? Doesn't mean that's the route you're going to be giving it by, right? Anyone ever watch Scrubs growing up? Yeah, so again, analgesic does not mean it goes anywhere other than that. Antipyretic, what is that? Relief fever, right? Good. So you need to know the indications for these drugs to know what you're going to be treating. So for instance, when you have someone coming in, say, into the ER, and they're presenting with fever, nausea, vomiting, etc., you can know, okay, well, I know for the fever, I'm going to use this drug. I know for the nausea, vomiting, I'm going to use this drug. For this infection that I think the patient has, I'm going to use this drug. Good to know your indications and what drugs are going to be used for, essentially. Okay, so again, pharmacology itself is just the study of the actions of drugs within the body. It includes interactions between drugs as well. Has anyone heard of a drug-drug interaction? Basically, one drug can either be antagonistic to another drug, or you may find certain drugs are synergistic in some cases. You may find that people are more likely to develop side effects when they start to mix drugs. So again, one of the big things we run into a lot from, especially from a toxicology standpoint, is a lot of people, we talked about opioids being pain relievers. When you start to mix that with alcohol or start to mix that with, muscle relaxants and other things, you start to see problems with that. So again, that's part of pharmacology. And you can break it down basically into two big categories. There's pharmacodynamics and there's going to be pharmacokinetics. Okay, so we'll talk about what these are. Pharmacodynamics is basically what the drug is going to be doing to the body, right? So for instance, if I give you an antihypertensive, what do you think that's going to do to the body? Lower your blood pressure, absolutely, right? So again, that's what the drug is specifically doing to the body. A lot of this is going to relate back to drug concentration and subsequent effects on the body. So for instance, if I increase the dose of a drug, of an antihypertensive, what do you think that does to the blood pressure? Should drop it even more, right? So again, there's usually going to be some sort of relationship between the dose of drug I'm giving and the effects I'm going to see. Typically, if I give a bigger dose of a drug, guess what? The bigger effect I'm going to expect to see. These can be therapeutic in a lot of cases. However, there's always going to be a threshold where people can develop toxic effects as well, right? It's where we see a lot of side effects. It's where we see a lot of issues that come about from that. Again, I see this a lot because when I have someone who's trying to commit suicide and they take all their medications at once, that's where you run into a lot of the toxic effects because the concentrations get so big. And then basically any other kind of miscellaneous effects of what the drug does. So again, pharmacodynamics, how the drug interacts with the body. Okay. And a good example of this would be ethanol, right? So again, here's an example of a dose, kind of a concentration sort of relationship with the effects of alcohol. Because again, ethanol is a drug, right? So again, not that any of you guys have ever used this inappropriately, I'm sure, but just as an example, is what people report, apparently. I'm just kidding. Very low dose, people develop things like a loss of inhibition, right? It's a kind of social lubrication, right? When I say that, what do I mean? more talkative, you maybe have to be a little bit braver, maybe like ask somebody out, they may not have otherwise, right? So that's kind of low dose sort of affects it, right? However, you start to get more moderate dose. Let's say I get into like 3, 4, 5 drink kind of range, I start to slur my speech, start developing coordination, right? So I'm going to be stumbling all over myself. Maybe that person I asked out is not going to really be all that interested anymore, which is unfortunate. But, and then very high dose, that's where we can start to see things like syncope, right? What is that? Pass out, loss of consciousness, right? Respiratory depression, which means I'm going to stop breathing on my own, and that can again lead to things like an brain injury, death, etc. So again, all of it is going to go back to the dose, right? And one of the things we'll see with talking about poisons is that anything can be poisonous in a big enough dose, right? Does anyone remember the Nintendo Wii? Okay, I'm sure most people probably had one growing up. I had a Nintendo Entertainment System in my house growing up, so again, that was when I was a very small child. So again, I feel older every day when I talk to you guys. But anyway, so again, there's a contest. If you guys remember, the Wii was pretty hard to find for a period of time when it first came out, and so there's a radio contest, and it said, okay, it's going to be hold your Wii for a Wii. And so they made these people drink a ton of water, and they had to hold it for as long as they could without having to go to the bathroom. And so, as you might imagine, you have that much water on board and you're not getting rid of it, it's going to dilute out several things in the blood, and one of those big things is sodium. You need sodium at the right kind of concentration, otherwise you develop seizures and you die. This lady unfortunately had that occur, and the radio station got sued for that. So water, you think water is pretty innocuous, even that can be poisonous in a high amount. Oxygen can be poisonous at too high amounts. So again, all goes back to the dose. Pharmacokinetics is going to be the flip side to dynamics, and it's going to be basically what the body is doing to the drug, right? So how does our body deal with that drug? Because most of the times, you can give a dose of a drug, but it doesn't stay there forever, right? Most of the time, your body's going to do something to it to get rid of it, right? Because again, it sees it as a foreign material. It's going to see it as a potential toxin. It's going to want to get rid of it, just like it gets rid of other waste products in the body. So this is where we're going to look at things like how do drugs get absorbed into the body? How do they get distributed throughout the body? Because again, if I'm dealing with, say, a twisted ankle that is inflamed, how do I get that drug? How does it get distributed from the time I take it orally? How does it get absorbed from the GI tract to get to that site where it's actual inflammation is occurring? And then we'll look at things like metabolism. We're going to look at elimination, right? So again, metabolism being what? When you think about drugs? Yeah, breaking it down into kind of waste products, and then it can then be eliminated usually through the kidneys. We'll also see like the liver can be important for eliminating drugs through the biliary tract. We can see lots of other ways that can happen as well. So again, kinetics are going to be what the body is actually doing to the drug specifically. Okay, so again, another example, going back to ethanol. Again, I always use this a lot, so people usually think I'm an alcoholic by the end of this class, but that's okay. Functional alcoholic is a key operative term there. So for alcohol-naive patients, so again, someone who does not drink regularly, so I'm going to assume every single one of you, they normally will metabolize, say, 20 milligrams per deciliter per hour. I mentioned that example in physio recently. Again, that is something you can kind of assume for most people. However, when you have someone who's a chronic drinker, so say they're drinking every single night quite a bit, they end up having the ability to metabolize much more than that. They basically have the compensatory mechanism. Their liver says, hey, we got all this alcohol around. We really need to ramp up production here of enzymes to get rid of this stuff. They may be able to metabolize, say, 60 to 80 milligrams per deciliter per hour. So much more quick than someone who's, say, alcohol naive. Right? So those are differences in kinetics between two different patient populations there. And those are things you have to take into consideration. So again, this is again what the body is doing to the drug. Okay, so looking at kind of the two sides of this coin here. So again, kinetics is basically what you're going to see whenever you have a dose of drug being administered, whether it's IV, PO. What does PO mean? Yeah, by mouth. PR, per rectum. Yep. IM, muscular, sub-Q. Yep, exactly. So again, any way that these drugs are going to be administered, they get absorbed through the body in some means, right? That concentration is going to be developed in the systemic circulation. When I say systemic circulation, I basically mean the circulating blood in the body, right? Because again, if I were to do a drug level, how am I going to get that level? You just had Clin Lab, right? How do I get those levels? Via the blood, right? I'm going to draw a sample of the blood. I'm going to be able to determine concentrations of drug within the body. That's a systemic circulation when I say that. But eventually, the drugs don't always work right there in the blood. They need to get out to the tissue, right? So this is where we're going to see that distribution, where it actually goes out into the tissues where it can have its actual effects. And then eliminations, where we're metabolizing and excreting the drug or the byproducts thereof and getting rid of it. And then what you see is that the drug concentration at the actual site of action, this is what we're actually concerned about from a pharmacodynamic standpoint. This is when that kind of takes over. So we're going to see what receptors the drug's interacting with. We're going to see what mechanism it actually has to cause whatever clinical effect I'm looking for. Also, what toxic effects may develop as well. Again, not everyone's the same. Some people can take a standard dose of a drug and have very good effects from it. Some people take that same dose and get very toxic effects from it. Everyone's a little bit different from that regard. But you can kind of see how the breakdown goes between the dynamics and the kinetics there. Okay, I mentioned pharmacogenomics, I think. Anyone, if you had to guess, what do you think that would be? So how your genetics play a role in how you handle drugs, right? So it's going to be things like I mentioned those SNPs. Remember those single nucleotide polymorphism, those things that can affect protein production. It can affect enzyme production. It can affect the ability for you to process drugs appropriately. You can find that some people, and again, a lot of this can go back down to specific mutations. Some of it actually goes back down to your lineage, your ancestry, right? So we know that some people from certain cultures are going to have an easy time metabolizing a drug versus people from a different culture may have a really hard time metabolizing a drug. It's important to take that into account because if you don't, you may have really toxic effects for some patients. You may not really have any effect on other patients. And so again, this is something that is going to be up and coming as you go forward. As tests become easier to run and cheaper, you're going to find that this is going to be much more done much more frequently, essentially. So just know that this is what we're talking about in pharmacogenetics. It's just how a person's genes are affecting how they can handle that drug. Okay, so I mentioned a drug. What is a drug? Basic, any kind of like foreign chemical sort of molecule that I'm introducing into the body, right? Sometimes we're actually replacing things within the body. So for instance, insulin, I can still consider a drug because I can give exogenous insulin, but typically it's a foreign sort of product here. But the key thing though is it's going to be causing some sort of biological functional change, right? So again, if I have high blood pressure and I take an antihypertensive, I should see the blood pressure come down, right? Those are kind of the effects I'm looking for with a drug, okay? And again, thinking back to those enzymes we're talking about, the lock and key sort of phenomenon, this is the same thing we're thinking about here, right? So again, drugs are going to have the ability to interact with the receptors, as we'll see in a second. Receptors are going to be the locks that the drugs are fitting into, and again, based on that, that lock and key sort of thing, you're going to see that certain drugs can only interact with certain receptors. Some of them may be very specific, and you may see there's only one very certain type of receptor a drug will interact with. Some of them may be very non-specific and can interact with all sorts of different tissues, right? And again, we'll talk about specificity later on in specific examples, but just know that specificity is going to be relating back to how many different types of receptors it may be able to interact with, right? So again, typically you're going to find a lot of these receptors are going to be located on the cell surface. Remember on that lipid bilayer, you're going to see all these kind of receptors poking out. That's where these drugs are typically interacting. However, some drugs may be able to get into the cell itself, maybe transported in, and they can have intracellular effects. So a good example would be steroids. So if you mentioned, people have heard of like prednisone or like methylprednisolone, like solumedrol, heard of those drugs? Those are steroids you can take for inflammation, and those actually work within the nucleus, right? Just like our normal steroids that we produce ourselves actually work. But just know there's different places they can operate there. Most receptors tend to be proteins, whether they're enzymes or they're transporters. In some cases, you may actually find DNA targets. So I mentioned with cancer, oftentimes with those really rapidly dividing cells, you want to interrupt that. And usually by interrupting the DNA, that's going to be one of the best ways to do it. And so you can have things like, antiviral drugs or chemotherapy drugs actually go in and disrupt that DNA and prevent cell replication, right? This could be one thing we can do. Now again, receptors typically play a regulatory sort of role in how much effect you're going to get from a drug. And so we're going to talk about this concept of up versus down regulation. But for instance, if I have a drug, say a drug A, and it only interacts with receptor B, if I take away receptor B completely out of the body, what do you think that's going to do with the effect of drug A? Shouldn't have any effect, right? Because there's no receptors for it to interact with. However, if I were to say have, say 10 receptors, maybe you get a certain effect, but if I increase that to have 20 receptors, you might see a greater effect from the drug, right? So these are going to be concepts we're going to talk about as far as like your body can actually try to compensate for having this drug effect around it, right? By changing the number of receptors that are available. We'll get into more examples of that later on, but just know that there's going to be this concept of by changing the availability of receptors, that can affect how well the drug's going to work, okay? Okay, and again, you can always go back to this kind of equation here where the drug or the ligand is another name for something's going to be binding to these receptors. We're going to stick with drug primarily, but again, they're going to be kind of floating around in solution. Again, they have to come together in order to have the effect there. And again, I can affect this in several ways. So for instance, if I were to increase the concentration of drug, I'm going to draw that force that equation over to this side, I'm going to get more effect out of that, right? So the higher concentration of drug, the more effect I should expect to get. If I have more receptors available, I should expect more drug effect from that, right? So these are things we can kind of affect to some limited degree. Okay, so I mentioned ligand's a pretty generic term. It's really any molecule that binds to a receptor. But again, these are all involved in chemical signaling. We're going to talk about those receptors and secondary messenger systems as we get into the next section here a little bit later on. But there's lots of different examples of that. So for instance, neurotransmitters. So again, things are going to be communicating neuron to neuron. So things like epinephrine, serotonin. We talked about serotonin a little bit, how it's kind of your feel-good chemical. That's the thing that kind of is playing a role in depression. Hormones, so things like insulin, which again, insulin does what to the body? Lowers blood sugar, absolutely. And cortisol, anyone remember what that is? It's yeah, so it can actually raise blood sugar, but it's a stress hormone, right? So again, and you're gonna find insulin and cortisol effects all the way throughout the body. But also drugs, acetaminophen. Anyone know what the brand name for that is? Tylenol. Or it could be other like messenger molecules. So it could be things like antibodies can be a role here. And we actually have a class of drugs that are just designed to be, we can engineer our own antibodies that we can inject to a person to have specific effects, right? So if you ever hear of a monoclonal antibody, or if you ever see a drug that ends in MAB, that's what that is. It's actually an antibody we actually formed, either synthetic processes or otherwise, and inject it into a patient, and that can have its own specific effects there. So lots of different things can be considered kind of a ligand. Okay, I mentioned a hormone is going to be any kind of natural substance that the body produces that should influence it in a variety of ways, typically to either grow or develop the body, or basically it's kind of our body's own drugs that they're synthesizing itself, right? So insulin, I mentioned, cortisol, testosterone, would be some other examples of hormones in the body. Estrogen, progesterone. Yeah, thyroid hormone. Yeah, absolutely. So like thyroxine would be considered a hormone. So any of these things can again, they're kind of like drugs that our body's producing in order to help control and regulate a lot of these kind of normal functions here. When I say xenobiotic, I probably won't mention this frequently, but that's just going to be a chemical compound that's foreign to the living organism. So insulin would not be considered a xenobiotic because your body produces insulin. However, acetaminophen, I don't know anyone's body produces acetaminophen. Probably never have a headache a day in your life, but most of you don't. And so again, that would be considered a xenobiotic. It's a foreign product we're introducing into the person. Okay, a toxin is just going to be basically usually a poison of some sort of biologic origin. So again, snake or spider venom. Do we have to worry about snakes in Florida? Absolutely, rattlesnakes, coral snakes. Those are the big kind of groups of snakes we have to worry about here. So again, hopefully you won't get bit, but if you do, that's considered a poison, right? Because it's a toxin because it's a natural biologic product. How about botulinum toxin? Do we ever use that for any positive purposes? Yeah, Botox, right? So again, if you ever see someone walking around, they're like this, they probably have some toxin in them from the botulinum toxin there, right? So Clostridium botulinum it's one of the most potent poisons out there in the world. A very tiny amount can kill a very large amount of people. However, we use this therapeutically. And of course, I always like driving down the road and I see signs are like, get Botox, $10 a unit, and I'm like, I don't want to be getting the most potent poison known to man off of a sign on the side of the road. I don't know that I trust those people that well, but Botox has lots of other purposes as well. But again, typically you're going to have harmful effects if not used appropriately, right? A toxicant is just kind of another variety where it's going to be typically a non-biologic origin. So again, a lot of our drugs we'll talk about are going to be toxicants in high amounts. Lead. Again, we talked about trace elements in the body being like small amounts of metals that we need, like selenium, manganese. Lead, though, is not one of those ones. Like lead is something you should have none of in the body. However, it can be a risk if in certain conditions there, right? And then toxicology, again, that's my area of study, is the study of the harmful or the poisonous effects of drugs. Again, I got really into that in pharm school because I was like, well, this is really cool to know what these drugs do at normal doses. What happens if I ramp it up to 11 and I mix them all together? And so you get kind of really cool effects out of that. And so that's what I really enjoy from a kind of patient management sort of standpoint. I don't do it on purpose to them, but they do it to themselves, and then I get to come in and play. So anyway, all right. So another very important term here is going to be agonist. Anyone guess what an agonist is going to be? You guys are in agony right now, but an agonist would be, yeah. So it's going to be, yeah. So it's going to have it's going to cause an effect on something essentially. That's a good way to think about it. So again, when a drug binds to that receptor and it activates it, right? So it's going to cause the effect to occur when it binds to that. That would be an agonist, right? It's going to be important to understand that versus the counterpart to that, which would be an antagonist, right? We'll get to that in a second. But basically, this is where the drug is binding to, either directly or indirectly in some cases, binding back to the receptor to have its whatever effect it's going to be. So for instance, if I have an agonist, say at the beta-2 receptor, right? So again, you guys are familiar with the sympathetic nervous system. We have various receptors that's going to activate. So again, there's beta-1. Where do you guys find beta-1 at? We're going to cover this in physiology, don't you worry. Beta 1's really found on the heart, right? So beta 1's a big thing that causes the heart to beat faster and harder. Beta 2, you're going to find on the lungs especially, right? So again, if you ever dealt with an asthmatic patient, or if you have asthma yourself, you know that albuterol is one of those life-saving medications for asthmatic patients. It's a beta 2 agonist, right? And so by activating those beta 2 receptors, that cause the bronchial muscles to relax, and that will open up the airway and allow the patient to oxygenate better, right? They'll be able to ventilate more easily. And so this is an agonist because it binds to that beta 2 receptor, binds to it, activates it, and then causes that smooth muscle to relax. Okay, so again, that would be an agonist because it's activating that receptor. Right, make sense? Again, you don't have to remember this specific example, but know what an agonist is doing. And if I say, hey, you have an agonist, what do you think that would mean? Those are the kind of the concepts I'm kind of focused on here. Right, I'm not going to ask you on this test what's the mechanism of action of albuterol. If I were to ask that in the next semester, we talk about asthma, you'd say, oh, it's a beta 2 agonist. Obviously, I know that. But in this class, it's not going to be that specific, okay? All right. And now, affinity is going to be a term we use to talk about how tightly a drug binds to a receptor. So again, low affinity means that it needs a lot of drug around just to even bind to that receptor and activate it. If I have a very high affinity sort of drug, it takes a very small amount of it to get in there and activate the receptor and cause whatever effect it's going to have, okay? And that's going to directly affect what we talk about potency. What's potency mean, do you think? Yeah, how strong maybe the drug is, one way to think about it. How much concentration you need maybe to get an effect out of the drug. And so this is important because we're going to talk about potency in regards to comparing different medications together, right? So again, for some drugs, I need milligrams of a drug to cause an effect. For something that's comparable to it in the same class, a different drug, I may need micrograms, right? It's a 1,000-fold difference between those two. And it's important not to screw that up, because if I were to give milligrams of this very potent drug, it's going to be bad for the patient, right? So again, higher potency typically means, and again, higher potency usually means higher affinity, usually means I need a smaller effective dose, okay? So for instance, morphine, everyone's familiar with morphine? What do we use that for? For pain, absolutely. So morphine is a very good pain medication, usually dosed in milligrams. Has anyone heard of fentanyl? Yeah, you're hearing a lot about this more in the news nowadays because the opioid epidemic, which I'll mention in a second, but fentanyl dosed in micrograms. So fentanyl in this case would be more potent because I need a much less drug, a much smaller amount of drug in order to get the same effect, okay? Now, when you're comparing drugs together and you say, okay, well, if I want to get, say, and how do you measure pain in a patient? Yeah, you ask them on a scale of 1 to 10. So that's usually the most common one. So say, okay, let's say what's your pain right now? You guys are in your pharm class, so it's probably like an 8 out of 10 or so, right? So again, so if I say, hey, if I give 5 milligrams of morphine and I can get you down to a 4 out of 10, and I can give maybe say 50 micrograms of fentanyl and get you down to a 4 out of 10, they have the same effect. That would be considered equipotent doses. And so that's important to understand when you're looking at different drugs in the same class. What's the equipotent dose between those two? So that way I can make sure I can convert those appropriately. Because again, in some cases, I may have, what happens if I've run out of morphine in the hospital? If there's a shortage and I have to switch over to fentanyl? I want to make sure I'm using an equipotent amount, because if I give 5 milligrams of fentanyl to somebody, guess what? They're going to be dead pretty quick, right? We're actually running into a big problem with this. So you guys are familiar with the OxyContin Express, or familiar with like Florida and a lot of pill mills? Opioid epidemic is a huge problem, right? So again, a lot of people are getting addicted to opioids. A lot of people are dying from this. In Florida was a big problem for a while. We had a ton of pill mills where people can go and fill all kinds of fraudulent prescriptions or inappropriate prescriptions for hundreds of OxyContin, Percocets, all kinds of good stuff, right? And so we shut down on that we cracked down on it pretty hard. A lot of those pill mills got closed down. A lot of people got arrested. And so when you run out of prescription drugs to abuse, does anyone know what you might move to get your prescription, or to get your non-prescription opioid? Heroin. Yeah, heroin is a big one. Some of you answered that a little too fast. No. But heroin is people, addicts, they will go to whatever's cheapest. And so they couldn't get their prescription drugs anymore, so they go to heroin, right? And so heroin, is a fairly potent drug, but what they're actually finding that all these people are starting to die. And they're like, well, why are these people dying all of a sudden? They were pretty experienced heroin users. Why would they die all of a sudden? What they're actually finding is that in order to get more kind of bang for your buck, these drug dealers were actually lacing their heroin with fentanyl. Of course, I don't really trust drug dealers to be the best chemists, and so they may not have been making the most pharmaceutically elegant sort of products there, right? And so they were finding that some people are getting way too much fentanyl in there because it's so potent. These people who were very used to heroin died, right? They basically had respiratory depression, unconscious, and they're dead. And so again, this goes to show you just the effect you can have with efficacy or with potency here, and making sure you're getting your potencies right, right? I don't recommend you give heroin to any of your patients, but just know that's an example of kind of the real world perspective. Anyway, clinically, you're going to find that efficacy is much more important than potency here. And we're going to talk about efficacy as being the drug ability to get the maximally desired response. Oh, yes, ma'am.
For equipotency, would it be like the same as like comparing Advil and aspirin to state since they're the same drug class, or would it be like Advil and acetaminophen?
So you're more correct when you're comparing Advil to aspirin, right? Because those are both going to be within the same category of drugs, right? Or if I was comparing like naproxen to ibuprofen, so I could say, for instance, how much ibuprofen do you normally take? You have a headache, so like 2 ibuprofen, right? Most people take 2. That's 400 milligrams, right? An equipotent dose maybe of aspirin may be something like 325 milligrams. Pretty similar in potency from that 400 to 325. Pretty similar, right? That would be a less of an extreme example than like morphine to fentanyl, right? So again, usually you're going to be doing this within the same class of drugs typically, right? However, you may, if you're doing on something objective like pain scale, I could use that in comparison of acetaminophen to ibuprofen. Maybe 400 milligrams of ibuprofen gets say a 2-point reduction in pain scale. For that same pain scale reduction for acetaminophen, I may need a gram. I need 1,000 milligrams of that. In that case, Advil or ibuprofen would be more potent than the smaller amount of drug, right? There's some graphs I'll show you that'll make this a little bit more clear as we go forward, okay? Anyway, efficacy is that ability to get kind of maximal desired effect. So again, with some drugs, they're always going to hit kind of a limit in how big of an effect I can get. So for instance, I can give acetaminophen, but is acetaminophen going to fix every person's pain issue? Not really, right? Acetaminophen's kind of wimpy in the grand scheme of things when you're comparing to things like fentanyl and morphine and Dilaudid and all these other things. So acetaminophen's kind of wimpy. It doesn't matter how much acetaminophen you give, you're only going to get so much pain relief out of that. You're only going to get so much efficacy out of it before you start to run into side effects and toxicity and other problems like that. What happens if you take too much Tylenol? Does anyone know? Liver failure. Yeah, liver toxicity is one of the biggest things we worry about with acetaminophen. Again, don't worry if you don't know those details right now. We'll get into that later on. Just know that's one of the big organ toxicities we worry about. People who are dealing with chronic pain, they may try to self-dose themselves. And they say, well, a little bit of Tylenol is good. Maybe I can take more of that and it'll be better. They don't realize you're going to hit a wall on that at some point and you're only going to get so much efficacy. So again, clinically, efficacy is much more important than potency. And when you're looking at drug references, and I put a link to on the site, on the course site, should be a link to what we call LexiComp. You can get that through the Nova Library, and I recommend that as kind of a good go-to drug reference. I can show you some examples of how to use that later on. A lot of people use Hippocrates. A lot of people use other drug references. Hippocrates, most people probably have that on their phone already, right? It's cheap and free. You're at least free to download for most of your phones. They already take that guesswork into account. They've already kind of figured out the dosing here. But again, we're trying to illustrate the concepts here, not necessarily to remember like, okay, well, is this drug more potent than this one? You don't really need to know that because when you're looking at the dosing, they've already taken that into account essentially. So you're looking at that, just know that's already been done for you from that standpoint. Okay. So again, I mentioned, an equipotent dose would be something if I need like 100 milligrams of drug A compared to 10 milligrams of drug B. If you get the same effect out of those, that would be considered equipotent. So we talked about that. All right. So now, just because you have an agonist doesn't mean they always are going to activate that receptor 100%. In some cases, you may find you only have, say, like a partial agonist. A lot of cases, you're going to have full agonists, which means when you have, when you say you take all your receptors and you fully fill them up with all the drug, you're going to be getting 100% effect out of that receptor, right? You're going to be getting 100% effect out of that. And so that's going to be in comparison to what we're going to talk about partial agonists and then antagonists here in just a second. So just know full agonist means if I activate that receptor, I'm getting 100% effect out of it. So partial agonists, though, will bind to the receptor and maybe only kind of partially activate. You only get maybe 50% or 75% out of that. And I'll show you some clinical examples of that in just a few minutes here. But it just means that it will get a lesser response, which means that it will have a lower total efficacy compared to a full agonist. That makes sense? Partial agonist, you're only going to get partial effect versus a full agonist. Typically, you're going to find that the response here, again, not equal to the max response. Even if I bind 100% of receptors, I may only get, say, 50% response, may only get 75%. It all depends on how much that partial agonist is really working with those receptors. So, again, just kind of a pictorial example here. Full agonist, you get 100%. Say, for instance, you get when you have 100% effect, you're getting a 10 millimeter of mercury drop in systolic blood pressure, right? Versus if I have a partial agonist, maybe I only get a 5 millimeter mercury reduction, right? So which one do you say is more efficacious? Yeah, the full agonist is going to be more efficacious. However, you may find some cases where this might be the preferable drug. I'll show you an example of that in just a minute here. Okay. So again, if you were to look at a graph of this, if you were to look at the response you get, so again, here's 0% response, you get no drops in blood pressure versus here you get full response. And concentration here on the x-axis, what do you kind of notice about this graph here? Yeah, you notice that plateau effect. What do you think is happening when you hit the plateau? You have no more receptors to bind to. You have 100% receptor occupancy at that point, right? So again, even if I keep increasing the dose of drug, it doesn't get any more effect out of that. That's the maximum effect you're going to be able to get out of the drugs when you're binding all those receptors, okay? So notice here with the partial agonist, even though I'm hitting that 100% occupancy, I'm still only going to get maybe 50% of that response, or maybe, you know, whatever happens to be. So again, partial agonists are only going to be partially effective compared to a full agonist. Now, an antagonist, a lot of times, you ever heard of like a beta blocker as a class of drugs, or it's another good example one. There's like alpha blockers, there's calcium channel blockers, there's all kinds of blockers that are out there. When I say blocker, typically I'm talking about an antagonist, right? So this is going to be something that's going to be preventing the receptor from ever being activated, okay? So it still has that lock and key sort of thing where like only certain drugs are going to interact with certain receptors. However, when it binds to it, you're going to have zero effect coming out of that, okay? And so this is going to block or reduce the action of agonists. And so usually what we're talking about are going to be competitive antagonists, which means that it depends on how much drug is around. So has anyone ever heard of the drug Narcan or naloxone? What is that used for? Reverses opioids, like morphine, right? So if I take too much morphine and I stop breathing, I can give you naloxone and that will wake right back up. Has anyone ever seen naloxone given? What's it like?
Patient freaks out.
Yeah, they freak out. It's like Waking the Dead, right? It's like someone go from completely comatose. There's a, I'm not going to show it here, but there's a movie called Bringing Out the Dead with Nick Cage and Ving Rhames. If you watch that, there's a scene that's on YouTube. Just search up Bringing Out the Dead Narcan. Watch that video. They will get a very accurate depiction of what it's like when you give someone Narcan when they're going fully comatose to waking up. Yes, sir.
My paramedic rotation accidentally slammed it.
Oh.
Yeah.
What happened?
I was supposed to get 0.4. I gave it 2 full milligrams. She literally like set up and like project up on
it. Yeah, it's like The Exorcist.
Yeah,
exactly. Pea soup everywhere. It's something else. You don't want to be like that person in the ER that's like, well, why is the cleaning crew here to clean up all of this? And you're like, it was me. I gave too much Narcan. But
me nurses are perfect. Once we got to the hospital, the nurse would give us attitude, just slap it and go.
Yep. Like, see ya. It's not very nice to your nurses. That'd be nice to nurses. Anyway. So that is an antagonist. That's something that when it blocks those opioid receptors, like the opioid receptors your body has, like it's going to produce no effect whatsoever. And so that's a competitive sort of effect there, right? So again, I can have normal morphine binding up that receptor, but as I start to introduce naloxone, that Narcan, as I start to get higher and higher doses, eventually there's enough of it to compete with that. It can kick that drug off the receptor, and now it'll bind to it and prevent it from having any effect. Right, so if someone's having nice, if I take a dose of heroin, I'm sitting there, I'm nice and chill, and all of a sudden I give that naloxone, guess what? I'm kicking all that drug off the receptor, and now I'm back to baseline essentially, right? I have 0% opioid effect there, and usually patients get pretty mad at you when you do that for them. But if you save their life, then it's all good in the end, right? Anywho, so that would be an example of competitive antagonist. Now, for instance, if I wanted to reverse that Narcan effect, I can give more heroin. I can give enough of that to kick that Narcan off of the receptor. But again, it's a competitive sort of thing. It's all a numbers game at that point, right? In some cases, I may have some drugs, some opioids. I have to give bigger doses of Narcan because there's more of a competition there. So I may have to give, you say give 2 milligrams, person wakes up, kind of exorcist style and vomiting everywhere. But for some opioids, that might not be enough. I have to give maybe 4 milligrams or 6 milligrams or 10 milligrams in some cases, because they're binding so tightly to that receptor. So again, a competition sort of thing is going to be on a kind of case-by-case basis, but you kind of get the concept there, right? Everyone with me so far? Okay, don't worry about so much allosteric antagonism. This is basically where it's going to bind to a different receptor site, so it may not actually sit here on where that drug would normally come and interact with it. Maybe it's sitting off on the side, interacting with another component of that to cause an antagonism. In some cases, you may have what we call a chemical antagonism, where, for instance, if we're actually able to take a drug and bind it up specifically and prevent it from ever interacting with the receptor in the first place, then you have your clinical effect. A good example of that would be with snake bites. Snakes, when they bite you, they inject venom into you, and the way we neutralize that is with what? Anyone know? Antivenom, right? So snake gives you venom, we're going to give you antivenom. Those are antibodies, essentially. They just like your body has antibodies against, pneumococcal or mumps or whatever it happens to be. We have antibodies we can administer to the patient that will bind up that snake venom. And at that point, once it's bound up, it can't really interact with the receptor anymore. It's neutralized, essentially, right? That's a chemical antagonism you can have there. You can also have functional antagonism, where the effects of a drug will indirectly inhibit the physiologic actions of the agonist. So for instance, if I were to say, and you see this all the time in clinical practice. So for instance, I have a patient who's hypertensive and they want to get their blood pressure down, I would give them antihypertensive. But what happens if I give them a drug that by its natural action would raise blood pressure? right? So for instance, a lot of weight loss drugs are stimulants, and I give them that stimulants, they're going to raise blood pressure. So that, you can see that they're functionally antagonizing one another, and so you see those kind of drug interactions all the time. That's a big thing we do from the pharmaceutical standpoint, is review patients' med list to make sure they're not having those interactions, right? So for instance, if I'm looking at a patient's med list and I see, okay, well, you have uncontrolled hypertension, but you're also on all these meds that increase blood pressure, maybe that's the problem, right? Maybe not, the answer is not to give more drugs, but to get rid of these other drugs in the first place, right? You may think it's counterintuitive that I say less drugs is better. Fewer drugs are better, I should say grammatically correctly. Fewer drugs are better for the most part, right? I don't want to add on more drugs if I don't have to. Again, drugs are job security for me. However, it's better for your patient if you get them on as few drugs as possible. And a lot of times, people are treating side effects of other drugs by giving more medications. That's never the right answer. Okay. Just a picture kind of showing an example of what, say, before you're giving the drug, say a natural chemical was here. Say, for instance, this is something like epinephrine, right? Epinephrine is a natural chemical your body's synthesizing. It can interact with the receptor and have its normal effect. If I give a beta blocker, which blocks the effects of epinephrine, it would sit there in the receptor site. It doesn't actually interact with those receptors, causing the effect, but it prevents the epinephrine from coming on and interacting with it in the first place, okay? Actually, I'm sorry, this would be if you have an agonist drug. So this would be like mimicking the effects of epinephrine. Here's a case where I'd be kind of plugging up the receptors and preventing the agonist from actually interacting with it in the first place. Okay? Kind of makes sense? All right. All right. So there are some cases where you can have reversible antagonists and you can have irreversible antagonists. A really good example of this is ibuprofen versus aspirin. Okay, most people are at least familiar with these drugs. Now, aspirin, you think of not only being taken for like a headache or for fever. What else do you normally see people taking it for? What's that? It's a blood thinner, right, for prevention of? Yeah, prevention of heart attack most specifically, right? And why do we use it for that? Yeah, antiplatelet effects. Again, don't stress if you don't know that right now, but again, we use it for its antiplatelet effects. The reason why we use aspirin, and typically people take how much? Usually a baby aspirin, they only need like 81 milligrams of aspirin. You don't need a really big dose. Like you can have an adult patient taking baby doses of aspirin to get good effect from that standpoint, from the cardiac standpoint, because it's an irreversible antagonist. Meaning once it binds to that platelet or binds to the receptors it's looking for, in that in this case, it would be an enzyme called cyclooxygenase. It stays there for good. For the life of that platelet, it's inhibited. Which is why I can give little tiny baby doses every day, and the patient's very well. Their blood is a little bit thinner, and they're less likely to have a heart attack. Versus a reversible antagonist would be something like ibuprofen. As soon as the drug is out of the system, its effects go away, essentially, right? So again, when you have to take ibuprofen, you just take like a one-time dose and you're done? No, usually if you have a continued pain, you have to continue taking it every 6 hours or so, every 6 to 8 hours. So again, that's one of those things that would be a reversible antagonist. Once the drug is out of the system, then you're going to find it's not really working much anymore, right? What time is it? Okay, almost time for a break. So you mentioned competitive antagonists. You can sometimes have non-competitive antagonists, which can actually bind to other sites and actually prevents the activity of an agonist in the first place. Again, we'll get into specific examples. Just know that there's some other ways that you can have antagonisms happening here, being non-competitive sort of mechanism. But basically, what you find here is you'll have drugs that will bind to a receptor, will change the conformation of it, such that the normal agonist cannot come in and bind to it. So it's just another means of getting some antagonism from that. Right? Okay, so here's an example. If I were to have, say, I'm looking at, say, an agonist effect, so say I'm looking at, say, blood pressure reduction, I'm looking at drug concentration here. Again, if I was looking at the agonist by itself, notice here that it's going to have whatever effect it's going to have. It's going to have, as you increase the dose, you're going to see you're going to have increased receptor occupancy, increased effect here. If I include a competitive antagonist, by blocking up some of those receptors, you're going to notice the effect is going to be limited here, right? So again, that's going to be something you're going to see very frequently if I give, say, a drug that raises blood pressure in conjunction with something that's going to be, or something that blocks those receptors, you're going to see minimal or lesser effects from that. Okay, so just know competitive antagonists are going to limit how efficacious my drug can be in the first place. Here's the example I was looking for in the slide. So again, opioid effects. Normally think analgesia. Again, there's heroin, morphine, codeine, Dilaudid, fentanyl. Any of these drugs are all in the same class as opioids. Again, we see the analgesia. A lot of people abuse it for the euphoria you get from those drugs. And then the big things we worry about from our standpoint is going to be things like respiratory depression, CNS depression. This is how people die from opioids, right? So again, if I was looking at opioid effects here, looking at a full agonist, has anyone ever heard of methadone? Methadone clinics? What do we use that for? They usually help people to get off of their opioids, right? It's usually to help with addiction treatment in many cases. So we'll talk about that later. But just know this is a full agonist. So you notice here that as I increase the dose, you're going to get a lot of effect out of that drug, right? Some people still abuse methadone, even though they originally used it as an intention to get off the drugs. Now, you can have a partial agonist. So what do you notice kind of comparing the partial agonist versus the full agonist? Lower max effect. So this is a drug called buprenorphine. Have you ever heard of like Suboxone or Subutex? That is a partial agonist. Again, also used for addiction treatment. But again, this is one of those partial agonists. It doesn't matter how much drug I give, I'm only going to get partial effects out of this, right? So again, I can increase the dose by a huge amount. I'm not going to get any additional efficacy of that. Versus if I have a full antagonist like naloxone, what do you notice here? No effect whatsoever, right? So again, it's one of those important things you're going to notice there. So again, a full agonist versus partial versus an antagonist, right? So this is a good way to kind of illustrate those differences there. I'm continuing. Let's do this. So going back to our turn, are any questions from the first half? Any chance? Someone had a question, what's the difference between like allosteric and non-competitive? You can kind of look at allosteric as kind of a subset of non-competitive antagonists. So again, for our purposes, just know there are another variety of non-competitive antagonists. Where that's kind of the big delineation you want to make there between competitive, non-competitive, essentially. Anywho, so specificity, we mentioned high specificity means what? Highly specific, right, for specific receptors, right, or specific targets. And so again, usually going to be acting through one or very few different types of receptors, right? This means that it affects a very specific cell type or tissue type, which is good in some cases. And this helps to limit a lot of toxicity, right? You're going to find that a lot of drugs that have multiple effects throughout the body have a very low specificity, tend to have more side effects associated with them. So for instance, if I'm trying to lower your blood pressure, doesn't mean I want to have effects on your GI tract, right? I just want to have effects on the blood pressure, right? But that's where side effects come from, essentially. So some examples would be something like antibiotics, right? Antibiotics are used for what? Kill bacteria, absolutely. So we're going to learn lots about bugs and drugs coming up in the fall. It's usually everyone's favorite section. Just kidding, most people have a hard time with that. It's a lot of drugs all at once, but it's okay. We'll get through it. But just note that antibiotics are typically very specific for dealing with bacteria, right? Because when I give a drug to kill off bacteria, do I want to kill off you as well? Usually no. Usually I do not want to do that. So typically I want something that's very specific. So for instance, if I can target the bacterial ribosomes, which are different than our ribosomes, that's one specific target. It's going to lead to fewer side effects for me, right? Or if I were to give you something that affects the bacterial cell wall, which is structurally different than human cell walls, that's going to be good, right? There's always going to be some bleed over. You're going to see that these drugs are not without side effects, but they tend to be more specific for those cells themselves. Versus when I was talking about cancer cells, is there a lot of difference between a cancer cell versus a normal healthy human cell? Unfortunately, no. And our drugs there, in a lot of cases, are not super specific. And so you're seeing a lot of side effects like the alopecia, hair loss, the suppressed immune system, all of that. And low specificity has multiple receptor activities. Again, not very specific for a particular tissue or cell type, more adverse effects. So has anyone heard of a tricyclic antidepressant? Right, so again, those are kind of an older school class of antidepressants we'll go into when we get to the psych meds later on, but just know that they were used for a long time because they came around before the advent of the SSRI. Anyone familiar with an SSRI? Yeah, so selective serotonin reuptake inhibitor, right? Again, don't stress if you don't know that. But an SSRI was a much safer drug because, again, this one only worked on serotonin reuptake, very specific, as opposed to a TCA or a tricyclic antidepressant worked on all kinds of tissues and all kinds of side effects. And so one of the things that we'll learn about antidepressants is that early on, you actually have an increased risk for suicidality. Doesn't make sense. You're like, I'm giving you an antidepressant, but you want to kill yourself. It happens, right? We'll talk about the mechanism for that later on, but just know that this is a very dangerous drug to overdose on. Versus an SSRI, very safe because it's very specific, much safer to overdose on than a TCA, right? So again, just an example. Chemotherapy drugs I mentioned, very non-specific, will affect healthy human cells versus cancer cells for the most part equally, and you see a lot of toxicity from that. Okay, now stereochemistry. Anyone remember this from organic chemistry? We're not going to get super in depth on this. I see a lot of people are like reliving those it's like those NAM flashbacks or something. So anyway, so again, most drugs tend to come in a racemic mixture. When I say racemic mixture, what does that usually mean? 50-50 between the left-sided version of the molecule and 50% of the right-sided molecule, right? And so again, we talk about things that are, this is basically looking at like, say, two hands, right? So again, your hands each have 2 thumbs and 4 fingers. I assume most of you have 10 fingers, right? But even though if you overlaid them on top of one another, notice they're not the same, right? You can't do that. They're kind of mirror images of one another, right? So we talk about, chemical entities that have the stereochemistry. Basically what I'm saying is 50% left, 50% right, okay? So this is important because you may find, and each one of those is called an enantiomer, right? So I can have the left side enantiomer, I can have the right side enantiomer, essentially. And so what you find is that one enantiomer may be responsible for all the therapeutic effects, while the other one is actually responsible for toxic effects. Some cases that can happen. And so what drug companies can do is they can actually separate it out and say, well, I'm just going to give the left-handed version, or I'm just going to give the right-handed version, and now I have a new drug, right? And now I have a new drug that I can administer that is going to be able to have fewer side effects and hopefully be more efficacious. So that is something you're going to see, and we'll point out those examples here as we go on. But also, which you're going to notice, and again, some people have accused me of being cynical sometimes, but they also get a brand new patent on those drugs, which means that they can get a new 20-year patent to sell that drug and make a whole bunch of money off of it. Because again, when you have a new drug that comes on the market, you can only get it as what? As a brand name drug, right? You can't make generics yet. There'll be a difference between generics and brand name drugs, but the brand name is going to be the only way you can get it for a long time. That's how they can make their money off of that. So again, they get new patents, they get a lot more money off of that. So some examples. So albuterol, we mentioned, is used for what? Used in the lung, used for asthma, right? So we can use it as a bronchodilator. So albuterol, say we give a dose of 5 milligrams of albuterol. That's 5 milligrams. 2.5 of that's left-handed. 2.5 milligrams of right-handed. I can give levalbuterol, which is going to be which version of it? Levo, yeah, the left-handed version of it, right, versus a dextroalbuterol. Dextroalbuterol is not administered. We give levalbuterol, and that's called Zopinex. It's a brand new drug there, and I can give 2.5 milligrams of that, and you get equally efficacious activity out of there, equipotent, because I'm only giving like the efficacious version of that molecule. Does that make sense? So again, you can see that, and you can know basically what the base, the parent drug is by looking at that suffix there, the albuterol. Okay, yes, I know it's albuterol. I know how it's going to work. It has the same mechanism of action. It's just only that one enantiomer. Another good example is citalopram or Celexa. Anyone know what we use that for? Yeah, it's an antidepressant. We actually use for lots of other things, but depression is a primary mechanism. But we have escitalopram we can give, or Lexapro. Notice here, 20 milligrams of citalopram equals 10 milligrams of escitalopram, right? Because we're only giving the active enantiomer in those cases there. Okay. Another good example. Anyone heard of Zyrtec? Yeah, it's over the counter now. Most people have probably taken Zyrtec. Cetirizine is the generic name there, versus levocetirizine. Again, the left-handed version is going to be Zizal. So 5 milligrams of that equals 10 milligrams of cetirizine. This is important because we actually do this when patients are getting admitted to the hospital. We'll review their medication list. And again, do hospitals carry every single drug known to man? No, it's not very cost effective for that, right? We carry what is used most frequently. In a lot of cases, we call that a formulary, right? Formulary is not going to carry every single drug. So in cases we have patients who come in and say they're taking Lexapro, that escitalopram, say they're on 5 milligrams at home, and they have to get converted over to our citalopram or Celexa that we have on formulary, then we can just convert them over from 5 milligrams of Lexapro over to 10 milligrams of Celexa. Make sense? Yeah, so again, keep those ratios in mind when you're thinking about those, because again, that may come up for testing purposes, perhaps. We'll see. Anywho, now these don't always, these kind of splitting out of the enantiomers does not always get done because of any kind of actual therapeutic efficacy. So this is a good example of my cynicism coming through. But I thought this was very funny. I looked at the Zizal website and it said, okay, wisely designed to be different. Active enantiomer of Zyrtec with no dextrocetirizine. Like, wow, that sounds pretty good. It sounds like we're getting just the active drug. Sounds great. And they put it right here at the bottom, very tiny print. The clinical relevance regarding the absence of dextrocetirizine is unknown. So why is it wisely designed to be different? We actually have no idea. We just did it, and now we got a new patent. Now we can make lots of money off of it. So again, when you're dealing with patients and you're prescribing them medications, a lot of times it may sound great to prescribe the brand new medication that the drug rep came by and they just give you a big lunch and they're talking about how great their drug is. But when you can get the other stuff for dirt cheap or over the counter, like just go with that, right? Because again, cost is going to be one of the primary motivators or primary decision makers for your patients. Because again, if you can't afford a drug, they're going to take it. No, right? And again, a lot of these older patients are on very fixed incomes. They don't have a lot of money to be spending on stuff like this. So again, you have to be very intelligent, very educated when you're making recommendations and writing prescriptions for these patients. Okay, so going back to definitions are downregulation. So this is going to be the process, and this goes back to homeostasis. This goes back to your body trying to keep the norm, right? It wants to make sure we keep things at a very stable baseline, right? So again, we have narrow ranges. We can kind of venture out of that standard, that middle ground, but we want to keep things normal with homeostasis. So again, whenever you have a drug come along and it starts to activate a receptor, your body's like, whoa, okay, things are different now. We're getting our blood pressure lowered. I don't like this difference. So it's going to respond by downregulating those receptors. It's going to say, okay, well, I don't like the way things are going. Let's try to get back to normal. And so it'll actually decrease the number of receptors that are available on that cell surface to interact with the drug. So what you may find with some drugs over time is I can give, say, 5 milligrams of drug every day. You see the blood pressure drop, and then over time you may see the blood pressure start to come back up. And that's a result of that downregulation that's occurring there, the body becoming more resistant to that drug. So in those cases, you may have to increase the dose of drug. You may need to give them a drug holiday where you kind of take them off of it for a while. There's different ways to combat that. But basically, fewer receptors means lesser effect that the drug can have. Make sense? So upregulation is the opposite effect that happens here, and this is usually going to be seen with antagonists. So if I block a receptor, the body's going to respond by trying to get more receptors up to the cell surface to interact with whatever the natural ligand is going to be. And so you can actually see some clinical issues that come about with this when you do things like take drugs away. So I might have an example in a second. Do I have that slide on there? Perhaps not. I'll show you a slide a little bit later of that antagonist effect, but just know upregulation is where you're going to have more receptors show up at the cell surface. Downregulation is where you're getting rid of receptors at the surface, right? Again, it's going to diminish drug effect versus upregulation will increase drug effect. All right. Now, bioavailability. Bioavailability is basically going to be another definition. There's going to be the amount or the percentage of drug that gets absorbed via a given route, okay? So this can vary pretty greatly by route of administration. We'll talk about routes a little bit later on. But just know, for example, intravenous. If I inject a drug directly into your veins, the bioavailability is what? 100%. Putting it right into the systemic circulation is all right there. I didn't lose any at that point. On the other hand, though, with oral administration, which again, what do you think is the most common route of administration we give things by? Oral, absolutely. So again, most drugs are going to be given orally if you look at the grand scheme of things. This can have 100% bioavailability. Things can be absorbed very well, or you may find some cases you have zero absorption. Some drugs don't get absorbed at all through the GI tract, and thus they're not going to be very good for getting it into the systemic circulation, right? So just know this is going to be basically, and when you're looking at drug dosing, you're going to see that they take into account this bioavailability. So for instance, if you look at say IV versus oral drug dosing, you can see they'll take into account how you have to change the dose. For some drugs, I can give 4 milligrams of something IV, and I can give 4 milligrams orally, and I should get similar effects. Some cases I may have to give 4 milligrams IV and then 8 milligrams orally to account for that lower bioavailability. And so they've kind of taken that into account already, but it's important that when you're converting things between different routes, you have to take into account what the recommendations are for those doses, because they can change pretty wildly. And actually I had a case just recently where I had a patient who came in, they were taking levothyroxine, which what do we use that for? Anyone know? Based on the name. Yes, for thyroid. So patient with hypothyroidism, we're giving them levothyroxine, and they were normally taking orally at home. So they take, say, 25 micrograms at home. So levothyroxine is a pretty potent drug, but they're taking 25 micrograms a day at home. And they were coming into the hospital. They came into the ICU, ICU, and they could not take anything orally. What do you call that? Yeah, NPO, nothing by mouth, right? So they were NPO at this point. They could take nothing by mouth. So I believe it was one of the providers was saying, okay, well, let's go ahead and convert them over to IV levothyroxine. And so they went ahead and did 25 micrograms IV. The kid's on 25 orally at home. They put him on 25 IV, and I said, wait a second, let me look at that. I looked up, and again, I look up everything too, right? I'm not going to know every single thing about every single drug, so I got to look up stuff. But so IV levothyroxine, I don't think that's going to have the same dosing if you give it IV. And sure enough, when I looked it up, it said you have to reduce the dose by 25 to 50%. Again, sometimes you have ranges like that, so I called it up and said, hey, probably want to drop that down a little bit. Let's go ahead and do, let's do half dose. Let's go ahead and do, say. 12.5 micrograms for that drug, and they're like, oh, okay, great. So again, those are little things you have to look up because otherwise we would have been giving the patient too much levothyroxine IV, and that can cause what? Hyperthyroidism, which would have been the opposite problem the patient had in the beginning, right? So again, these are little things you have to take into account. Now, the reason why the oral bioavailability can be so different, one of the big things is going to be this issue called first pass effect. Anyone ever heard of this? What is first pass? I don't know. Basically, you can think about this as the liver tax. This is basically when you absorb things from the GI tract, the first organ it's going to hit predominantly is going to be the liver. We're going to learn that in physiology, but you'll see that the GI tract is going to go into the liver, and they're going to find that the liver is the main site for drug metabolism. Most of the metabolism happens within the liver, and so a portion of that drug, as it goes through the liver, is going to get metabolized. And then you'll have some that will get out into the systemic circulation, right? So again, it goes in from the liver back to the venous supply, and they can circulate through the rest of the body. So if I have something that's metabolized very well through the liver, I may have a very high first pass effect and may metabolize all that drug. That could be one reason why you have no oral bioavailability. However, I could give it IV and it works okay, right? Some drugs you're going to find no first pass effect. And then again, you may find that the bioavailability is close to 100%. In those cases, the IV and the oral dose may actually be very similar to one another or maybe identical. So again, first pass effect can vary widely depending on the drug. And again, when you're looking at drug dosing, they've already taken this into account. Okay, makes sense? So another term would be a prodrug. Anyone ever heard of a prodrug? It's kind of the opposite of like an amateur drug. Like acetaminophen, an amateur drug, like morphine, prodrug. No, I'm just kidding. So prodrugs are actually going to be drugs that are inactive in their current form. So if I were to take a drug and it's inactive, it would be considered a prodrug. However, when I send it through the liver and it metabolizes it, it'll break it down into an active form of the drug. Okay, so a good example, has anyone heard of Vyvanse before? What do we use Vyvanse for? ADHD. So the Vyvanse is a drug called lisdexamfetamine. Okay, so you can see the drug name here, right? So and again, if you notice the kind of the root here, what is that? What type of drug do you think that is? It's an amphetamine, right? So again, most of the ADHD drugs we're dealing with are actually it's a form of amphetamines, right? So you're giving your kids stimulants, or you're taking stimulants, and you're taking these drugs. And one of the things that can happen is you can become addicted to these medications. Some people will abuse these medications for various purposes. And so one of the things they run into, people take their Adderalls or their Ritalins, and they would crush them up, and they would try to snort them. Very similarly, if you're snorting cocaine or snorting any kind of amphetamine. And so they were doing that in order to get a high. And so they were like, well, what if we gave a prodrug that, and again, one of the things you'll notice is when you give things nasally or any route other than oral, you skip the liver for the most part. You skip that first pass effect, right? So you increase your bioavailability. So one of the things they noticed is like, well, okay, well, what if we change the drug, made it a prodrug, so that way if they snort this lisdexamfetamine before it gets converted to dextroamphetamine, it has no effect for them. So that is in a way they were able to deter abuse by making it into a form that actually is very hard to abuse from any route other than oral. When you give it orally, it'll go through the liver, it'll get metabolized into this dextroamphetamine, and that's what's working for your ADHD. Kind of make sense? Again, they did that for kind of high-risk patients for a while, but then now they realize Vyvanse works great for most everyone, so I see a lot of patients on Vyvanse nowadays. So very, very popular ADHD med you're going to see out there. But again, that's the main thing, is the prodrug. It's inactive in this form. Once it gets converted in the liver, be the oral route, it'll get converted over to the active form here, right? Another good example would be something like codeine. Anyone ever heard of codeine before? Codeine is another analgesic drug in the opioid family, pretty wimpy sort of opioid. Actually gets converted over into morphine, and morphine is actually the active component there, right? So again, you can kind of consider codeine to be a prodrug in some limited respect. But this is another good example right here. This is Vyvanse. Okay, we'll talk about volume distribution much more in the pharmacokinetic section here, but just to get the definition out of the way, this is basically a measurement of how distributed out into the body and into the tissues that the drug is going to become. So I mentioned when I take a drug orally, goes to the GI tract, gets absorbed, goes to the liver, and then it gets into that systemic circulation, right? So it's in the bloodstream. Does it all just stay in the bloodstream? No, I want it to get out to the tissues where it can actually have its mechanism of action. So again, if I sprain my ankle, I want that drug to get out of the blood and get to the site of inflammation, right, if I'm taking ibuprofen. So how well distributed out to the tissues that the drug gets will tell you how big of a volume of distribution it has. Some drugs have a very high volume of distribution. They'll partition out into the tissues very easily. Some drugs are going to stay very much more in the central circulation. Have a very low volume distribution. So just to know, this is going to be a measurement of that. We're going to get much more into detail later on in the pharmacokinetics section, so don't fret about that. We'll talk about this in greater detail there. Okay, so getting into the actual specific routes of administration, again, more on the practical side of things, or how we're going to be giving drugs. So we mentioned a few of these already. We mentioned IM, we mentioned IV, we mentioned subcutaneous. Whenever we say the term parenteral, parenteral is mainly going to be things we're giving via injection for the most part, right? So if I'm giving something IV, if I'm giving something sub-Q, IM. So if I say parenteral, that's what I'm meaning there. If I say enteral administration, what does that mean? Oral. It means by mouth, right? So again, enteral administration would be by mouth. Parenteral usually means via IV most often, but it could also mean, IM, sub-Q, any of those things. So we're going to get into the details. We're going to talk about pros and cons of each sort of route of administration here, as we're going to see. And again, there's lots of different ones, lots of different ways we can give drugs. Yes, ma'am.
I was going to say the enteral could also be like gastric if they have a bleeding tube.
Absolutely, yeah, true. Yeah, so there's lots of different routes here. Sometimes we'll give drugs actually duodenally, sometimes, depending on where the tube's actually placed. But yeah, absolutely. Anything going through the GI tract, I guess, would be a more specific way to say that. So here's some of the routes we're going to talk about here. Again, don't memorize these numbers specifically, but the concept here is important. So just know that when I give something IV, you expect to get 100% bioavailability because, again, I'm putting it right into the central circulation itself. Everything else is going to have, could have 100% bioavailability, but in some cases we're going to have lesser bioavailability. And again, the one's going to have the most variation here is going to be orally. There's some drugs that just cannot give orally because it'll have 0 bioavailability. Some drugs I can give orally and it's fine. So it just depends. So just note there's a wide range here with the oral administration, but again, everything's going to have a bit of a range to it unless it's given IV. IV is 100% every time. Make sense? Okay, so we'll talk about some of these details here on the characteristics side as we talk about each one individually. Okay, so IV drug administration. What's some of the advantages of giving a drug via IV? What do you think? Quick, right into the bloodstream, right? There's intravenous. There's also intraarterial administration you can do. Intravenous is by far the more common one we're going to be administering drugs by. Yes, ma'am. Good, so you don't have to worry about the GI tract having any negative effects on it. Like sometimes drugs are not acid stable. Sometimes they may not be able to go through the GI tract because of that. Very good point. Right, that's one benefit. What else?
You can control how much.
So I can control how much. So one of the other things you're going to see is that drugs can either be given as a single bolus. When I say bolus, what do you think that means? Boom, draw the drug at one time, right? I'm giving one big dose at one time, versus sometimes I give it as an infusion, right? An infusion would be something I'm giving it over a period of time. Some drugs, when I'm giving an IV, can be over an intermittent infusion, where I'm saying I'm giving a drug over 15 minutes. May give it multiple times a day, but I'm giving over 15 minutes, versus something that goes as a continuous infusion. Continuous infusion means I'm giving it 24/7 for as long as that patient needs that drug, right? And that's nice because I can actually titrate how much of that drug I'm giving. So for instance, if I'm giving a drug to raise blood pressure, I have a septic patient who's hypotensive, I can give them a drug to raise their blood pressure, I can titrate that drug if it's a continuous infusion. I can give them a little bit more if their blood pressure gets too low, I can cut it back down if their blood pressure gets too high, right? And keep those things within range. So that's another benefit there. The other big thing to note here is going to be, right, so it's a fast onset, very titratable. Again, the bioavailability is 100%. So that's the other big benefit of giving things via IV. Now, is it really easy to get IV access on a patient? Is it always easy, I should say? No, some patients are very easy. Some patients you're going to find are much more difficult. Who do you think might be difficult? Yeah, so people who may have multiple injections done all the time. So again, patients who are in and out of the healthcare system very frequently, who get injections a lot, they tend to have scar tissue buildup over IV sites. Drug abusers as well, because they're injecting themselves quite frequently, they can be very tough. Any specific ages of patient? Yeah, elderly patients may be potentially difficult. Is he more difficult than them? On the other side, peds, yeah, peds can be very, very difficult. Dealing with, imagine you're having an infant who is, maybe 5-6 kilograms, and they're in a code. Like they're having a code through cardiac arrest, and you have to get an IV with those little tiny veins. That can be very tough, right? So we'll talk about some other ways we can get around that, but very, very tough to get IVs on patients. So again, not always the easiest route of administration, but very, very much the most direct route we can give it. And again, the other thing to consider is whether we're giving drugs via central versus a peripheral administration. So as a central administration, what do you think that means to you?
Infection.
Risk
of infection.
Yes, so anytime you have an IV that's being placed, you always have the risk for infection. Anytime you're introducing foreign material into the bloodstream, yeah, absolutely, infection's at a risk. But this is more relating to where is the drug actually being administered at within the body. So for instance, if I get a vein in the antecubital, that would be considered peripheral administration. I'm giving it a peripheral sort of area, right? Versus central administration, basically that means that we're going to be placing something called a central line. Anyone heard of the central line before? That's basically mean we're having a catheter that's going to be given and basically kind of empty out into the IVC, right, to the inferior vena cava, right? So again, what's the benefit of giving it right there? Right to the heart. Right to the heart is a large amount of blood. So again, the big thing here is you're diluting it out very quickly, okay? So typically you want to give drugs that are more concentrated or that may be irritating to the veins. You want to give them more centrally because again, when I dump it out into the vena cava, lots of blood there, dilutes out very quickly, goes right to the heart, and I'm good to go. Versus peripherally, you can run into some issues. Here's an example of what we call purple glove syndrome, secondary to an anti-epileptic or anti-seizure drug called phenytoin. So phenytoin itself is very hard on the veins, and if it extravasates, anyone heard of the term extravasation before? It's basically I'm injecting drug and it gets out of the vein. So say, for instance, I punctured the vein and it starts to infiltrate out into the area. It's called extravasation. And that can be very bad with phenytoin. You see that tissue necrosis happening right there. That's a lawsuit waiting to happen, right? So that is one of the reasons why we don't like to give phenytoin peripherally. If I can give it via central line, it's much more safe because it gets much more diluted when it dumps out into the blood there, right? So again, that's one of the things you have to consider there. Other things you have to be careful of is the compatibility of drugs. So for instance, if I give 2 drugs together, they may make one another come out of solution. So here's an example of putting calcium and phosphate together. So say and I deal with this all the time. So has anyone heard of total parenteral nutrition? I'm sure you have. So it's going to be TPN, if you ever hear that. It's basically we're giving a patient cannot take any food orally, so we're giving all their nutrients via IV. And so we're giving them fats and carbohydrates and lipids and electrolytes and everything via IV. I have to worry about calcium and phosphate, because if I give them too high amounts of each, they're precipitating out. And what do you think that might do in the veins? Cause an embolus, right? And so I can see some big issues with that. It may actually, in some cases, may actually calcify out in the line, in the actual IV line, and that can be a problem with that to then change that out. But if it happens in the patient, it can be deleterious to them as well. So you have to be careful with that, and look up things like administration of different drugs together to make sure they're compatible. If they're not, then you can run into issues like this. So what are the negative effects or the cons of giving things via IV? Yes, ma'am. Okay, sure. So once I give the drug, it's there. I can't take it back, right? So it not only goes for it to have an allergic reaction, but also like the dose that I give. So say, for instance, your example, you meant to give 0.4 milligrams of Narcan, but you accidentally gave 2 milligrams of Narcan. That would be something where once that 2 milligrams in the patient, guess what? You ain't getting that back out. All you can do is wait for time to happen for that naloxone to get metabolized and get eliminated. So again, once you give it, you cannot take it back, which can be an issue there. Mission precipitation there and extravasation being a big issue as well with certain drugs. Okay, most places you work will have protocols on what to do in cases of extravasation. Try to limit tissue damage, but you can be very careful with that and try to make sure you have good line placement beforehand. So let's say I'm dealing with that infant, I'm dealing with a small kid, and they're coding, they're in cardiac arrest, and I cannot get an IV very easily. Is there another way I can give drugs via right into the bloodstream? IO, yeah, so my emergency medicine people know that. So IO, what does IO stand for? On the next slide. Nope, sub-Q's on the next slide. Intraosseous I'll talk about though. That's a way we can actually give drugs directly through the bone and into basically that into the marrow, where it's basically a big non-compressible vein. So I think I have a picture of that later. Do I have that? Anyone know? Look forward in the slides. Yeah, all right, perfect. So I'll talk about it there. Anywho, so some other parenteral routes we can give drugs are going to be sub-Q, right? So subcutaneous administration. This is nice because, again, can most people give an IV to themselves? Generally, no. Drug abusers are pretty good at it for the most part. However, most people tend to not have that kind of skill set. So, but sometimes they need parenteral drugs to be administered, and they need to go home. They don't want to keep people in the hospital all the time. So this is a good means for patients to administer parenteral drugs to themselves. Another big thing we see this used for are things like insulin. Now, insulin's a protein. One of the things you'll learn about proteins, they don't do too well in the GI tract. Like you mentioned, like the stomach acid can tear them up. We have proteases and other enzymes that's going to tear that out. So we cannot give oral insulin. I have to give it via sub-Q means, and this is one of the most common ways we're going to do that. So again, good for easy administration. So insulin's the biggest one. Sometimes we'll do this with anticoagulants. So anyone heard of Lovenox? Some people give themselves injections of that. Also good for implants. If you do like birth control implants of progesterones and things like that, that can be done for kind of long-term birth control purposes. This does have the higher bioavailability than you would see for, say, like oral administration. However, it will not have the same fast onset as IV. IV is the quickest way to get drug into the body. This is going to be a little bit slower than that. So again, if you look at like insulin characteristics, it doesn't happen immediately. It takes a little bit of time for insulin to really kind of kick in and have its effect there. But it's going to be also slower than intramuscular, as we'll see in just a minute. Some of the disadvantages can cause pain. A lot of people don't like to inject themselves, especially if they do it multiple times a day. So that can kind of be an issue. And then you may also see some tissue necrosis, especially with anticoagulants. So just know there's some drawbacks to this as well. Also, one of the big things you have to do is make sure the patient's educated on how to do this, because what do you think would be some issues if they were, say, using improper technique? They weren't like cleaning things well. Infection, yeah. Infection is always going to be a big risk whenever you're dealing with parenteral stuff. If you're introducing the skin cooties into the sub-Q space, that can be a source for infection there, so you got to be careful. Okay, next we have intramuscular administration. Again, this is going to be less invasive than IV. Anyone can get an IM. It's pretty easy, usually like in the deltoid or other places. Very good high bioavailability. Pretty fast onset. Not as quick as IV, but still pretty fast. Some of the disadvantages here, it can be very painful for patients because, again, you're injecting fluid into the muscle and you're causing that muscle to expand somewhat. That can be painful for the patient. Typically, larger volumes equals more pain. And so in some cases we actually have to split out the injection into multiple injections to make sure the volume is not too much. For instance, like, usually 3 mLs is the highest amount of drug we can give via like a single IM injection. It's not important you memorize that number, but just know that more volume equals more pain, and that usually limits what we can do, which also means you have to get drugs very concentrated in order to administer this, because otherwise, we just can't get enough drug in that volume. This also requires blood flow to go to the muscle to be absorbed. So if I have a patient who's not maybe, we mentioned septic patients or hypotensive, and primarily the body wants to send blood to what two places? Brain and the heart, right? So again, the muscles tend to take a back seat to that. So if I give an IM injection and the muscles are not being well perfused, that drug does not get absorbed as well. So you need good blood flow to the muscles for that to work. You may have some patients that are obese or emaciated, may have altered absorption as well, which can kind of be an issue there. Sometimes you have to judge your needle length based on the patient's kind of habitus, so that's important things to consider. And then also you can have things like exercise and heat may actually affect absorption as well. What do you think this would do if I increased exercise, increased heat? What do you think that would do to absorption? Speed it up or slow it down? Speed it up typically, right? So again, because if you're hot, you're vasodilating, getting more blood flow. If you're exercising, more blood flow is going to the muscles. That would increase absorption. Good. Some other injection sites you may have, gluteus maximus used occasionally. Sometimes in the lateral aspect of the thigh can be used as well. So again, not done as commonly as IV, especially like in the hospital setting, but can be done with some regularity. Especially if you do not have IV access, this is a good way to go. Okay. Has anyone heard of intrathecal drug administration? This is where we're actually going to be, one of the things you'll notice with the CNS, central nervous system, is it doesn't like a lot of stuff to cross over. We have what we call the blood-brain barrier, and so there's a means that we can actually get around that by actually injecting drugs right into the epidural space there. And so this is a good way. Anyone know what kind of applications we might use this for? Who might get an epidural? Pregnant, yeah, people going into labor, right? So again, it's one of those things where if I give a drug IV, guess what? The entire body is going to be affected by it. However, this is nice because I can kind of limit the effects of the body by where the drug's actually going to within the spinal cord. So usually you'll find anesthesia being injected into the epidural space for things like blocks or for labor like that. Because again, for a pregnant patient going into labor, do you want the entire body to be numbed up? No, you typically only want kind of lower half to be numbed up, and so you can manage that with things like epidural administration. So that's one good application for it. In some cases, we may give like chemotherapeutics, so we'll give like intrathecal drugs for cancer patients, antibiotics occasionally, but anesthesia is probably the most common thing we're going to do for that. And if you work in surgery, you're going to do these with some regularity, or you're going to see them being placed with some regularity, right? So very frequently. Up next, we have an intral form of administration. It's going to be the sublingual, right, or SL if you see that. So this is actually nice because this is one of those ways it bypasses the liver to miss that first pass effect. So again, this would be something where you just kind of place the drug underneath the tongue and allow it to be absorbed from there. You don't want the patient to actually swallow the drug in that case. The other big thing that's nice here is it doesn't require to be absorbed by the GI tract. So if it's something that had kind of low oral bioavailability, it may have better chances to be absorbed right there in the mouth. So that's good. It's also good for patients who can't really swallow pills or who are actively vomiting, right? So for instance, Zofran or ondansetron. Anyone heard of Zofran before? Zofran's like liquid gold in the ER. It's like what everyone's coming there for, basically. But Zofran usually comes as an ODT or an orally disintegrating tablet, and that way just sits there right in the mouth. It can absorb. If the patient's not really in a place where they want to be swallowing, and you could induce some more vomiting there. So it's a very common thing we give in the ERs. Disadvantage: not many drugs are absorbed that well through the sublingual route, so it's not done frequently. Does anyone know any other sublingual drugs you might give? Yeah, nitroglycerin is the other big one. So you might see some nitroglycerin, little tiny tablets put underneath the tongue, and they'll do that on the onset of chest pain for angina. Right, good. Obviously, oral is going to be the most common one we're going to do with this. This is the most common, the safest, and most economical method, right? So there's no need for procedures like getting an IV or intrathecal administration, anything like that. But the most economical. Some of the disadvantages, though, you need the patient to actually be compliant, right? What does compliance mean? Actually doing what you're telling them to do, so them actually following your instructions is important here. So they're not compliant, they're not taking the medication, guess what? It's not going to be that effective, right? So you have a patient who will come in and you're giving them an antihypertensive and they come back in, their blood pressure still right where it was, and you're like, hey, are you taking your medications? And what are they going to tell you? Of course, yeah, of course I am. Yeah, patients lie. Like, it just happens. So again, sometimes compliance can be difficult to assess for your patients. It's hard to tell whether the drug is actually working or not, or whether they're just not being compliant. Patients have to be able to swallow a pill. You can find issues with this in elderly patients. Certain disease states like Parkinson's is a big one, where dysphagia and dysarthria occur, which can make it difficult to swallow medications. So, and some patients just don't like, certain dosage forms. So, for instance, if I'm giving a tablet or pill, capsule. Some patients just do not do well with trying to swallow those. So I have some patients who are, 17-year-old in the ER, and they're still requesting liquid medication. I'm like, come on, you're 17 years old, you can't take a tablet. Some people have a real problem with that, and so we have to, make sure we can give liquid medications to overcome that. First pass effect, though, again, is going to be entirely dependent on the drug. Some will have no first pass effect, some are going to have 100%, and they cannot be used orally, so it'll just depend. And then the other big thing you have to worry about is food-drug interactions. So has anyone ever heard of Cipro before, or Levaquin? What kind of drug is that? Antibiotic, very frequently used antibiotic, but the class that it falls into is called a fluoroquinolone. You're going to sound much smarter when you come out of my pharm classes, because you're going to be able to say things like hydrochlorothiazide and fluoroquinolones and all kinds of things like that. You impress all your friends. But one of the big things to note with the fluoroquinolones is when you administer them orally, you take them with something like calcium found in milk and other dairy products, they can bind up to one another. And so now you're binding up that antibiotic. It does not get absorbed. And what do you think happens to that infection? Keeps raging on, right? So it's one of those things where it's like, okay, well, I give you this antibiotic course, you did not clear the infection. Is it because the drug didn't work, because you have resistant bacteria, or is it because maybe there's some other interaction prevented the drug from being used very well, right, or being absorbed very well in the first place? So there's lots of different dosage forms. I mentioned capsules, I mentioned tablets, there's liquid formulations. Enteric coating, has anyone heard of the term enteric coating? What do you think that means? Yeah, so it prevents it from being affected by the stomach acids, so it can get down into the small intestine and be absorbed there. So this, when I say acid labile drugs, it means that they get disintegrated or they get metabolized in acid and acidic environments like the stomach. So we can coat those in order to get down to the small intestine. So if you ever hear enteric coated aspirin, that is one example where you may see that. And then there's also a lot of controlled release preparations. And so there's lots of different ways you can see this being called. You may see XL for extended, extended length, or SR for sustained release, CR, controlled release. These are all medications that are designed to be released over a long period of time, usually over 12, 24 hours to allow it, so that way you don't have to take the drug multiple times a day, right? And again, the thing with compliance is the fewer times I have to give a drug, the more likely the patient is to be compliant, right? I can barely remember to take a multivitamin one time a day, and I'm a pharmacist. Imagine someone else trying to take, drugs 3-4 times a day. Sometimes it doesn't happen. So just know that there's those kind of extended release forms as well for many drugs. Okay, there's also the rectal route. So again, a good advantage of the rectal route, it's good for patients who cannot take oral medications, right? So for instance, if I have, say, like a infant, right? So my 5-month-old right now, if I try to give her an oral medication, probably not going to go too well. Probably going to get a lot of it spit back out at me, right? However, if I give something rectally, going to be well absorbed there. The rectum is very highly vascular. It has very good blood flow. It gets absorbed easily, and it's, as long as you hold the cheek shut, she's not going to be able to spit it back out at you, right? So again, that can be one of the advantages of using that. However, it's going to be very patient dependent. So imagine, and we see this all the time. So we give enemas via the rectal route frequently for constipation, right? So you're here like a Fleet's enema, that's what we give it for. And a very frequent complaint in the peds ER is abdominal pain. And most of those abdominal pains are what? Constipation. A lot of kids are just FOS, right? Full of stool. And so we get the x-ray back, look like full of stool, and sure enough, we give them an enema. And so I have one doc who is, we always increase the supply of enemas available in the ER when he's working, because he's just like the enema king, right? For whatever reason, that's just the way he works. And so, you think about like a little kid giving enema, okay, that makes sense. Like, they're not going to fuss too much about getting a rectal medication. He's just like 15, 16, 17-year-olds, and I'm like, dude, like, no one wants to get an enema if they don't have to, but so again, very patient dependent in a lot of cases. But other big things with rectal administration, you miss the first pass effect, so you can get very good absorption of drugs through that route as well. Depending on the gastrointestinal tract and how, if you're having diarrhea or things like that, it's very easy to kind of lose the medication if it has not had time to get absorbed yet, so you may need to think about that. Kids are much more pliable with this than adults are going to be typically. Now note here, the suppository normally comes in a foil wrapping. I do recommend removing that before administration. Oh, it's a real pain in the butt. It's not good. So So you can take that out. Usually these are going to be like a cocoa butter base with the drug is in that. You'll administer it rectally. Again, it doesn't have to go super far in, just into the rectum. And usually they'll hold it there, allow that cocoa butter to melt, and then the drug gets absorbed very quickly. So the more common drugs you're going to see with this are going to be like acetaminophen suppositories. That's probably the number one rectal thing you'll see there. There's also some laxatives and things like that, but Tylenol is probably the biggest one. Okay. There's also inhalational therapy. So again, what type of drugs are given via inhalation for like what disease states? Yeah, asthma's a big one, right? COPD, all those kind of respiratory kind of conditions. We usually use respiratory meds. And so the advantages here is it gives drug directly to the area where it's needed. So for instance, if I'm inhaling a dose of albuterol for an asthma attack, it gets right to the site where it's needing to work. I don't need to give it orally to go through the whole system, and it goes right to the lungs. That's good. So asthma medications are the most common things. You're going to see meds for COPD. Those are the most common things we give orally. In fact, you can even give insulin or via inhalation, I should say. I'm sorry if I said orally, but inhalation. There's a few formulations that have been out there. They're not super popular, but you can actually do that. But in some cases, you may have very fast absorption of certain drugs. So anyone familiar with crack cocaine? Not personally. I'm just asking. You're really familiar with the concept of the drug. Usually, you think cocaine. You think usually the cocaine hydrochloride. You actually have to snort. That's probably the most common. It's like Wolf of Wall Street sort of era, right? Eventually, they learn how to freebase cocaine, and you can actually get it to a smokable form. And the reason why people smoke it is because when it gets to the lungs, it goes. Gets absorbed very quickly. And if you think about the route of blood through the body, it goes from the lungs. Where does it go to from there? It goes to the left side of the heart, and goes to the left side of the heart to where? Everywhere, namely the brain, right? So again, it's a very fast way to get onset of drugs, which is why crack cocaine is so addictive, because you get levels so high, right? So quickly. So again, it can be a very good place for absorption. A lot of times, though, we're giving it to get very specific action within the lungs itself. So think like albuterol, right? Again, we're not going to be prescribing cocaine all too often. However, cocaine can be prescribed, right? It's actually, we use it sometimes for ENT surgery. We'll talk about that later on. But cocaine is actually a medicinal product, right? Anyway, so the disadvantage of it is very dependent on patient technique. So if you're using it like this, not working so well, right? This is one of those things where you have to educate the patient very well. The patient must be able to work with this. So you imagine see like a meter dose inhaler like this. If you see MDI, it means a meter dose inhaler. If they are not going to be able to coordinate between pressing that canister and inhaling that drug, guess what? Drug's either going to be exhaled out, or they're going to just go down into the stomach. It doesn't get to the site where it's actually needed. So patient technique is super, super important here to get that right. There's a meter dose inhaler, which usually has a propellant to it. So there's a normal kind of like asthma inhaler you think about. There's also dry powder inhalers. I've never seen those discus sort of inhalers. Like those are usually like a dry powder where the patient's providing kind of the inspiration. That's what's drawing the drug into the lungs themselves. And then the more common thing you'll see like the EMS or in the ERs is going to be nebulization, right? This is where basically going to be pouring a liquid into a cup that vibrates at very high frequencies, and that generates an aerosol that the patient can then breathe in a little bit more passively, right? So people have a tough time with this, especially inhalers like this, little kids. People have maybe like arthritis and cannot coordinate that super well, like in elderly patients. So again, very, very dependent, and education is very, very important here, right? I thought this was very funny when I saw this. I'm trying to see if this will work. Perhaps. Or not. It'll probably work for you if you look at it on your slide, but basically would have been funny, but it's not going to be funny if it doesn't work. All right, I'm just going to move on. You can watch that. Oh, here we go. So an episode of House. This is why the teach back method is very important, because you want to educate your patients and see how are you actually using it. You may think that's dumb, but I've seen dumber, okay? So that's why it's always important, like when you're educating patients, like have them teach back to you what they're supposed to be doing. And when I say something like, take 2 pills twice a day, what does that mean to the patient? You gotta make sure that information has gone over to them well. They may think, okay, well, I take 1 pill in the morning, 1 pill at night. It may not be correct, so you have to make sure that you're assessing their knowledge or their understanding all the time. Anywho, next up is going to be our transdermal route of administration. So transdermal is obviously going through the skin, right? So there's going to be patches and things like that. They're going to be placed directly on the skin. Also creams and things like that are placed topically will be considered transdermal. The advantage of this is that it is usually going to be in a patch that can be placed less frequently than what you may give like via oral medication. So some of these patches will last 1, 3, 7 days depending on the drug. So it's nice from a compliance standpoint to just slap it on and then don't have to worry about it for a few days, right? The other thing is if you have a patient with like Alzheimer's and they have memory issues, guess what? They forget to change it. The drug's not going to be all that effective after that period. So you got to be careful with that. Not all drugs are going to be able to penetrate the skin, so this is where we talk about things like lipophilicity. Remember how well it gets absorbed into fat is going to be important here. So again, if the drug doesn't cross the skin, doesn't matter how much of it you put on the outside, it's not going to cross, right? And usually this is going to be dictated by this kind of this passive diffusion. You're going to have a lot of drug here in the patch that will force the drug across the skin, and then it can get absorbed into the systemic circulation. Other things you don't want to use it on the open wounds, would have increased absorption. And one of the big things we run into, problems with kids and poisoning, is that those patches, when you take them off, they still have a lot of drug on them, because again, they were working based on that concentration gradient there. So there's a lot of drug on those. So if a kid gets into one of those patches and swallows it, that's a nice controlled release amount of drug it's going to be absorbing for a long period of time. We actually had one kid who presented to the ER. He was probably like 8 months old or so, and was coming in for lethargy, just not acting right, the parents were really concerned about him. And so they're going through, and the blood pressure was low, heart rate was low, and one of the drugs we use for hypertension that we'll place on the skin is called clonidine. Ever heard of clonidine? Like Catapress. It's a common one you may see as a patch. And so, we're interviewing the parents, like, okay, what drugs are actually in the household? And, going through and like, no antihypertensives. The dad's like, oh, I'm on a clonidine patch at home. And I was like, oh, this looks a lot like the kid actually swallowed a clonidine patch. And the guy's like, there's no way the kid could have. He's 8 months old. He's not that mobile yet. And I was like, is there any siblings in the house? And he said, yeah, there's a 2-year-old in the house. And I said, aha. I guarantee you the 2-year-old picked up a patch out of the trash or something and fed it to the infant. And the dad's like, there's no way that happened. Absolutely not. And so I was like, well, let's see. So we ended up admitting the patient, treating him for that, managing blood pressure and whatnot. And sure enough, 2 days later, kid pooped out a patch. Never felt so smart in my entire life. But they were like, you said it, and that's what it was. And so, yeah, so be very careful, because again, a lot of drug is still left on those patches, even when they're used up by the patient. Okay, some other routes, we will cover these as they become as they come up, and the actual drugs we'll talk about. So for instance, we talk about glaucoma, we'll talk about ocular administration of drugs. There's oral administration of drugs, which means where? Into the ears, perfect. And then there's a lot of mucous membrane administration we can do, so things like the vagina, urethra, nasal administration. We'll talk about those specific instances as they come up and as they become relevant. Okay. So yeah, a few minutes. So So basically, who regulates drug development? The FDA, the Food and Drug Administration, right? So they regulate not only food, but also drugs and also cosmetics. Basically, they're responsible for making sure that drugs are being produced by Big Pharma are safe and efficacious for patients, right? And again, this isn't always the case. Before, a long time ago, drug companies didn't actually have to show that the drugs were even efficacious, or really even that they were safe, right? So this is, way back in the day. However, there were some events that transpired that kind of required the FDA to kind of put in some of these regulations. So, for instance, the Food and Drug Act. This is the kind of the big act that kind of encompasses all of like drug development and sale to the people. Basically, want to make sure there's no adulterated or misbranded food or drugs. Is kind of the big thing that thing says. But it had nothing regarding safety and efficacy. They just wanted to make sure that if I had a bottle of heroin, that it was actually heroin. Yes, Bayer makes aspirin, used to have heroin they would sell, right? However, in 1938, so again, very long time ago, they had this 105 kids that ended up dying because there's this elixir sulfanilamide. It was an antibiotic, and actually contained a very toxic compound called diethylene glycol. So they used it as a solvent, ended up killing a bunch of kids. And so because of that, they developed this Food, Drug, and Cosmetic Act, the FD&C Act. And so this was starting to say, okay, well, we need to really show that things are going to be safe and efficacious for people, along with this Harris-Kefauver Amendment. And this basically came about from thalidomide. Anyone ever heard of thalidomide before? You know what kind of happened with kids who took, or moms who took thalidomide? Basically, there's a term called teratogenicity, where if a mom is exposed to a drug and the kid has a negative outcome, that's a teratogenic effect. And there's a drug called thalidomide that's used over in the UK for a period of time, where moms would take it during pregnancy for nausea and vomiting, and the kids were coming out with malformed limbs. Basically, had these kind of flipper sort of like appendages that were forming there. And so because of that, I said, well, wait a second, we really need to like test these drugs out beforehand to make sure these drugs are really safe and effective before the people actually get them. So this is where a lot of these kind of rules kind of came about from. You don't have to memorize all these individual instances. I'm just trying to show you kind of where we were at and where we're at now, right, or where we came from to now. So every human drug trial, this is the stuff that I probably would want you to know, normally has 4 phases to their trials. Everyone's heard of like, a phase 3 trial, phase 1 trial. These are the phases they're talking about. So basically there's 3 clinical phases, and there's going to be 1 post-marketing phase. So every time you take a drug, guess what? You're in a clinical trial. You're in the post-marketing stage of those trials now. Now, before a drug actually gets into those clinical trials, they produce an investigational new drug application. This is what a drug company would submit to the FDA. Say, hey, we got this new drug. We would like to use this for human testing. Obviously, they have to do a lot of preclinical testing beforehand, like on animals and things like that. And this will include information on like the pharmacology, toxicity, etc. So then they're going to have these 3 phases here. Usually phase 1 trials are going to be in around 10 to 100 healthy people. So these are people without the disease state. So I'm giving an antihypertensive drug that I want to market. I'm giving it to healthy people. This is usually going to be to determine dose. I'm trying to figure out, okay, what's really a safe dose for these patients there. In phase 2, once they pass phase 1, they will have 50 to maybe 500 patients that actually have the disease, and they're going to determine how efficacious it's going to be. So I'll see how well their blood pressure actually responds to that. And then finally, in phase 3, they're going to be testing maybe thousands of people to see safety and efficacy. So again, by the time you actually get the drug out to market, this may only have been tested in several thousand people. And can you really actively tell, like, those 1 in a million sort of side effects with thousands of people taking it? No. So there's a lot of things we find out in that post-marketing trial, and that's the reason why some drugs actually get taken off the market, is because of the stuff we find out when they're given to millions of people, essentially. So you can kind of see how there's many chemical entities that start out the process. They eventually get weeded out, so eventually they get to these phase 4 trials where something actually makes it onto market. So again, very few drugs actually make it to this point. Again, that's why R&D costs are so heavy for these pharma companies, is because there's so many of them that are going to be actually non-viable for the most part. Just another graph kind of showing you kind of what's going on in these processes here. But again, phase 1, really, is it safe? Trying to learn things about kinetics. Phase 2, does it work on the actual patients with disease? And then phase 3, does it work? This is where they're doing things like double-blinded trials. We'll talk about that in FE-Bio later on. But the final thing is, once it actually gets onto the market, phase 4. So again, this is post-market surveillance, is where we're looking for side effects when people, just in the general public, are actually taking the drug. And note that every drug patent has 20 years. So by the time you submit it to the FDA, right about this time, this is where you get the IND, you have 20 years to get it out on the market and make your money back. So if it takes you 15 years to get that drug on the market, you only have 5 years left to make your money back, versus if it goes through pretty quickly. So you can kind of imagine, like, things like, an enantiomer of an already known safe drug. I can get that through pretty quick comparison because I have a lot of safety data already for the racemic mixture. I can get that and have more time to make that money. And after this point, this is where you can start to make generics. Okay. Again, just another table kind of showing you the differences between these trials here. I'm not going to get super in detail on the actual specific types of trials, but just know the kind of the number of patients you're going to be dealing with, right? So again, it's not until you get to phase 3 where you really have a few hundred to thousands of patients actually taking the drug. And you can see the kind of the research cost here is pretty expensive. Okay. And then, providing all 3 the phases of the trial are effective, and they show that they're safe and they work. At that point, they get approved to the market, on phase 4. And then at that point, there's no fixed duration. That we're always monitoring for new side effects and things like that. But the average cost to bring a drug to market is like about $2.6 billion. So you can see why. Not to say that drug companies are not greedy and embolden their shareholders. However, it is pretty expensive to bring drugs out in the U.S. Okay. So any questions on that before I let you go? Sorry, I went over a few minutes. All right, well, have a fantastic weekend. I will see you guys next week.